It's always interesting when you get squeezed in the middle. And I don't want to cast aspersions on which of these is David or Mike on the outside or their sexuality. I don't want to have done that. But I'm afraid the person that sent me this picture last week, I thought, I'm having that. That so sums it up. When Louise said, you won't be minding being in the middle. So if during my time as a professor you see me looking slightly like that, you'll understand why. Okay. I want to take the opportunity, and I will not run over. I know I've got my 20 minutes and I'm going to get a look of time if I do. So I want to discuss the importance of outcomes in tissue viability. I want us to consider that as 4 things: prevention, assessment and differential diagnosis, management and maintenance. Obviously, one of the key things is about quality and safety in tissue viability, and for me that is about us achieving those outcomes, and it's also about demonstrating them. Now, this is a global issue. It's a massive, massive issue, and I think the key driver for the real interest that's occurred more recently in tissue viability is there is a desire to reduce the amount of spend. Now, my desire might be about improving quality and might be about looking at improving outcomes. But the things that I receive in my role in as a consultant nurse will be about how we can reduce cost. So there's a massive amount of money being spent in the NHS, and one of the things is about, are we getting it right? Now, it's always mandatory if you're going to speak in tissue viability, and I learnt this from Trudy Young, was that you would always have some good pictures. So I've dealt with mine now. The rest of mine will not be gruesome, so for those of you who don't like looking at these things, they're over and done with. Now, we've been faced with a barrage of things from the Department of Health telling us about the things and where we're going. So we've had the delivery of health and social care is going to face radical changes. And I'm sure you're all aware of the latest bill and that the debate and the discussion that are surrounded and the amendments to that bill. Some people will see this as liberating the NHS, and some people may see it as stifling the NHS. Now, I want you to just think about what outcomes are. The Department of Health says to us that we need to reduce mortality and morbidity, we need to increase patient safety, we need to improve the patient's experience, we need to have increased autonomy and clear accountability. And one of the things I often say to people when I'm speaking to them is, if you're up for the job, then this all feels okay. And maybe if you're not quite up for the job, then maybe you might be thinking of retirement. I have considered being a stay-at-home Jackie. I've considered it very frequently. But it's not for me. And I think I drive my poor husband and child mad. Too much energy. Thank you, my dear sister Linda. So we espouse that there's a shift to clinical credible outcomes rather than targets. And for those of you who have worked in an acute trust will probably be, fair to say, fed up of targets. So not for me without me, and I have to say, this could have been written about me. I am a woman not to be trifled with. I know that's how I am. And I'm a bit, I don't want somebody doing something, and you're nodding in the front, Vi. But putting the patient first is actually really important, and I love the fact that Mike thinks that I've been nursing much longer than I actually really have. I only qualified in a few years ago, and I don't remember some of those early things in tissue viability. Honestly, I don't. So, I come from a community nursing, district nursing background. I've been privileged to get the opportunity to train as a district nurse, and it's been a great experience for me. So I just want you to focus now a little bit on community nursing. I think there are 100,000 nurses working in the community in the UK, and I think that's quite a lot of staff who need education, training, support, encouragement, cajolement, and in some cases even to retire. Now, 1 in 4 people over the age of 75 need a nurse's care at home, rising to 1 in 2 people over 85 years. In total, they visited 2.6 million people a year. 50% of community time within Worcestershire, from our productivity improvement data over a 2-year period, demonstrated it was 50% of their time was spent on wound care. So we've got an increasingly elderly population, we've got earlier discharge, or for us, we've even got avoidance of admission. And we've got the treatment of people with increasingly complex needs at home. So this transparency and outcomes framework from the Department of Health offers information about how you develop an NHS framework and how to improve healthcare outcomes, and that they will be a priority for the NHS, the primary purpose. So it seeks good measures in terms of, rather than processes, about how you measure healthcare interventions. Now, these are distinct from your processes, and it's that thing about, I just want you to think, if we give people a pressure-reducing cushion, we might be able to tell you how many people we've done that for. What we might not be able to do is tell you how many people actually prevented developing a pressure ulcer. So the emphasis for the NHS on their outcome framework is what actually happens to the health of the patient. What is the outcome that you achieve? And is that as a result of the treatment and care they receive? And that's always difficult because the two may not correlate. As you saw earlier, Mike's slide where he got a treatment that was an empty box. That may be coming to an NHS near you soon. But we are going to be funded around healthcare outcome measures. So actually, we are going to have to look a bit smart. Now, Enoch and Price say that complete wound closure may not be an appropriate outcome measure. And I think it's fair to say, for those of you who work in tissue viability, you would absolutely agree. Now, there's an additional view around outcomes. Do you measure it at the end, or do you measure certain things as you go along? And if you're going to measure certain things, what might those certain things be? And are they supported by the evidence? What's interesting is, whilst we're talking about outcomes from the Department of Health and the government, Transforming Community Services identifies pressure ulcers and leg ulcers as areas for improvement, but they're not actually in the outcomes framework. And I don't believe that the people in the Department of Health will have the skills to be able to come with the measures that we're needing to demonstrate. The patient experiences are going to be at the heart of the NHS reforms. And what I'm going to propose is that we need incremental steps in terms of those outcomes so that we can demonstrate that we can achieve them, and we can achieve them by providing high quality evidence-based care. So I want you to just think about your outcomes and just think about how we might focus. So I've included 4 areas that I see as being really important. Now, I know predominantly some people will miss out one of these, but I think all of them are really important. So that's your prevention, and I think there are a number of significant concerns about the number of people with diabetic foot ulceration that again go on to lead to amputation. I think there is significant concern about pressure ulceration. For me, I'm passionate about the fact that we need to get assessment and differential diagnosis right. We need the skills to do it, and we need some outcome measures that say people have got the skills to do it. We need to think about management and about it being evidence-based. And we need to be able to say we can manage certain things in particular ways and the types of outcomes that we are expecting to see. One of the things that's often ignored is about maintenance. And sometimes we don't see improvements for patients. They have a chronic wound and we're not able to improve it. We're not going to prevent it, we're not going to diagnose it, but maybe what we do need to do is to maintain it if we can maintain it so that they can be independent and that they can be infection-free, we still achieve a lot for our patients. So I think maintenance is my bit of a, we need to focus on that. It's an important outcome that may be very important for patients. Now, often when you present your ideas about things, you present them going along in a continuum. You're smiling, David. So you might present them as such, or you might present them like this. And I'm just going to say to you, does the health service and does provision of tissue viability focus in this way? Is that big area at the top on prevention? Is less on treatment, or is it more like this? And I think if we're really serious about healthcare and we're really serious about looking at outcomes for the future, actually, we need to view it very differently. It's going to be important for us in the future that we identify essential outcomes. And today, Louise and I have met with some people, and I think that we have achieved quite a lot in terms of developing some work around our first outcome. Things around skin care are really important, and I'm going to say that because my dear husband has spent a fortune in Estee Lauder for the last 24 years that he's been married to me. Darling, thank you, and it's worth every penny. Leg ulceration. It's going to be particularly important for us to demonstrate our outcomes. And whether that's care that's delivered in a leg club or whether that's care delivered in another way, we are going to need to demonstrate those outcomes. Now, I do not proclaim expertise in diabetic foot ulceration, but I recognise that it's a really important part of tissue viability. And actually, it's an area where we can really, really make a difference. So, for me, outcomes are going to be important for the future. The government says they're going to be important. We need to develop some more robust evidence-based care, and we need our pathways and what actually happens to patients so we can measure our outcomes to be based on evidence, and we need to have certain points at which we start to do that, and it isn't all about healing. Information generated by the patients is going to be really important and really critical to this process. And I know that last year we developed a pressure ulcer prevention and management treatment form, in patient information in our organisation. And we sent across our organisation, and 96 people were involved in its development. And then we sent it to our patient forum, who absolutely took it to pieces. So I've learnt from that is that I might go and talk to them before I develop it, and it goes to 96 people next time. But it is important because we can learn a lot of things from patients, particularly the Leg Club members I will cite when I went out to interview them and using keywords. And the use of keywords was very good because we were able to capture a lot of information in a relatively short time. And I certainly think it gives a flavour about their evaluation of the service. Getting some patient experience data is really important, and it was interesting this week in the Strategic Health Authority meeting where they talked about, for the first time in their meeting, they're going to have a patient talking about a patient experience. And I have to say there were probably about 200 of us there, and 150 of us tissue viability nurses sort of did a sharp intake of breath as we wondered what they'd been doing for the last 20 years. So the Queen's Nursing Institute has done a rather large survey, and they've done it with patients, and saying to patients, and it's literally 18,000 patients, so I think there's some value in this, is what is it that you're wanting to see in terms of care delivery? And they wanted three things. They wanted staff to be competent. They wanted you to be confident. Now, I don't know about you, but when you looked around perhaps on your tour earlier on, it took me back to my training, which, as I say, wasn't terribly long ago, but it took me back to there. And did I feel confident? No, I didn't. And it took me a long time to build that confidence. There's a high expectation. Now, Gojia Brzezinski has said, caring is none so apparent as when it isn't there. And I'm sure if you've ever experienced poor care, you will know exactly what that feels like. So, the Queen's Nursing Institute says it requires providers to have comprehensive training and a development framework. Now, I think part of our role here at Birmingham City University is to work with organisations and to work with staff in terms of helping them have that development framework, and in terms of people taking much more adult and a responsibility to their education and training. I think we do need to have particular standards around competencies, and I think those competencies may well lead back to your outcomes. There will be great pressure on us as to whether we have qualified nurses or we have healthcare assistants providing service in the future. What will be important is that we're able to demonstrate our value. And what I've learnt from my post is if you are able to demonstrate your value, is people keep coming back. Unfortunately, sometimes they're asking you too much, too often and too frequently. And as always, it's difficult. It's difficult to say no, but it's always important to deliver. So, if we increase the knowledge and understanding of support staff and our generalist practitioners, and we care for individuals in acute and community settings, and we also enhance some of the specialist tissue viability services, and we empower patients, will we make a difference? We need to start with our pre-registration education and training. And Louise and I wrote our first poster, I daren't say it, at least 10 years ago about pre-registration education. And it probably was a bit of a rant on our part and a disillusionment at the fact that we still hadn't and weren't able to get that into the programme. I'm pleased to say that that's very much in the programme here, so congratulations to Pat Davies. I think she's done fantastic work here. Pre-registration preparation is really, really, really important, and I applaud your work because I know you've done a lot of it. But we need to be comprehensive in that, and I know that we can make a difference there. And I know from my work in Worcester that we can get students who really, really want to be involved. I think for pre-registration students, we need to focus on outcomes, and we need to get them thinking about the outcomes and the things that they can achieve. One of the big challenges of this role is around creating the culture. And you might call it a paradigm shift, but it is about creating the culture and getting winning hearts and minds. Large-scale change always poses us with challenges, but it'd be very much easier to stay where we were. If we're going to have this increasingly elderly population, what is said is that we're going to need to promote health and well-being, and it needs to be more central to our planning. And we really need to focus on what it is that the patient really wants to achieve. So an outcomes framework, which I think that we can contribute to here from Birmingham City University, it will act as a catalyst, and it will drive up quality, and it will promote equity and excellence. I think we can develop patient care pathways. I think that they will go out for intense scrutiny and discussion, but I think part of our role here is to begin that. What we need to do needs to be measurable. We need to think about wounds in an international context, because the challenges we face here are what we face everywhere. So in terms of patient expectations, a strong commitment to prevention, appropriate assessment and differential diagnosis, no decision about me without me. Wouldn't you want to be offered appropriate evidence-based treatment options? Do you want to know about the things that you can do to look after yourself? Do you want good quality patient information? Do you want to be referred to a specialist if you're not progressing? If you're not going to get an improvement, would you quite like to even just maintain and stay where you are? Do you want to live as independently as possible? And do you want the people looking after you to be well educated, aware of current assessment, aware of those management options? Because I think the patients expect this, and I think they expect no less. And I think as we move forward, patients will be much, much more articulate about what they expect. So there are a number of outcomes I think we can focus on, and whether they're educational or whether they're clinical or whether they're about research outcomes or whether it's about leadership outcomes, and that's very difficult to measure, is how you win hearts and minds. One of the things in my role is acting as that agent for change and trying to bring that change and being tenacious and not giving up and holding that sticking power even when it's frustrating. Let's just take some of us back to 1960, and I think it's a very nice quote by Henderson. I'd like to think that here there is no limit to the influence we could have in tissue viability, and many people have written to me, and thank you very much for the cards, flowers and all the things that you send. The world's your oyster is what people have said. In terms of progression through one's career, one meets and encounters a variety of people that influence you. If you were mad enough to send me your image, I'd like to say thank you very much for those of you. And if you're looking and not recognising yourself, yes, Ed, that is you. And yes, wives are great things. Thank you also to Claire Stevens for sending hers. It did cost me a drink and a glass of wine, but there you go. Thank you very much to all of you who have supported me. I think we can make a difference at Birmingham City University. I do, jokes apart, genuinely look forward to working with my colleagues and professors. Here's my world-famous picture. And for all the men who are still looking at the Wellingtons, of course. So the ladies will have looked at the Wellingtons and the garden and the plants, and the men will have seen the red thong. It's all about perception, isn't it? You've only just seen it. It's not me. No, honestly, it's not me. I don't have green Wellingtons. It's definitely not me. I'm not confessing. No, please. Too much heckling from the audience. Outcomes can be about perception too. And it's about how outcomes are perceived, isn't it, by different people in different places. The government may view outcomes very differently to how you and I view an outcome. And I think one of the things that belies us within tissue viability is to be more clear and more explicit about what those outcomes are going to be. And I think sometimes when we're faced with a patient, and I choose particularly, for example, a patient with palliative, with a fungating wound, I think we do have to be realistic and honest, and I think we do have to take time to listen and to explain, and I think we do have to be clear about what those outcomes are likely to be. So, thank you very much for listening to my session around outcomes in tissue viability. I offer you a number of references, obviously, which any of you can go and look up. And can I say thank you for the opportunity, and I'm going to say it. A particular thank you to Louise Toner, for whom without her none of us would be here tonight. Thank you.